Hello everyone, I'm Suzanne Perrier, a DNP FNP graduate student, and this is a quick educational video about an invisible phenomenon called post-intensive care syndrome, or PICS for short. First, a big thank you for your participation. It's an invaluable contribution towards the success of this capstone project. Also, please remember to take the short post survey. We really appreciate it. During this presentation, we'll be discussing what PICS is, why you should care, and what we all can do about it. First, I have no conflicts of interest to disclose, and with that, I hope you enjoy this presentation. In the past, the goal was acute survival in the ICU, and success was seeing patients leave alive. But what does life look like after they discharge? Now, as modern medicine advances, we're seeing more and more patients survive critical illness, and this is excellent news. However, in the last decade, research has really illuminated many of the devastating consequences associated with ICU survivorship. Up to 50 to 80% of all ICU survivors are discharged home and subsequently develop a constellation of new and debilitating symptoms that may last for years. In 2012, the Society of Critical Care Medicine coined the term post-intensive care syndrome, or PICS, to describe this phenomenon. A systematic review by Kamdar et al. Followed over 10,000 previously employed ICU survivors and found that at 6 months after they were discharged, 66% were not back at work. And then when they went back and checked 5 years after discharge, 33% of the survivors were still unable to return to work. This is just one of the ways PICS continues to devastate patients, households, and communities all over the world. So what is post-ICU syndrome? PICS is made up of 3 symptom categories: cognitive, physical, and psychological. Patients may experience symptoms from just 1 or 2 of these categories, but an estimated 20% suffer symptoms from all 3. Next, we're going to discuss a patient testimony. This is a real-life example of a patient suffering from PICS. His name has been changed, and obviously this is not an actual picture of him, but here is his story. Craig is a 51-year-old father and successful CFO of a large company. He was in a motor vehicle accident that resulted in hospitalization and emergent surgery. Thankfully, Craig survived, but he required ventilation for 6 days and spent 3 weeks in the ICU. He was recovering really well with the help of his family and regular PT, and after 3 months, he was even cleared to return to work part-time. Then, at his 6-month follow-up appointment, Craig and his wife came in and reported that he was back to normal, and he seemed like it until they did the cognitive exam. When asked, Craig was unable to report the current year, the current president, and failed to recall the color of his car that he's had for over 10 years. Then, upon further investigation, Craig admitted that he was also struggling at work. He could not remember how to perform simple tasks that he'd previously breezed straight through. And despite seeming fine to friends and family, Craig was eventually asked to step down from his position as CFO. And as a successful accountant of 20 years, it was difficult for him to admit that he couldn't remember how to manage his own books, let alone the company's. So this is an example of how PICS can be a largely invisible disease, even to the patients themselves. It is so important we raise awareness and get survivors the early treatment they need. So now let's talk further about the cognitive impairments. Evidence suggests around 30 to 80% of ICU survivors develop long-term impairments. A study of 821 ICU survivors at 1 year after discharge found that 40% had global cognition scores worse than patients with moderate traumatic brain injuries, and 26% had scores similar to patients with Alzheimer's dementia. It's important to know that PICS cognitive impairments are difficult to recognize. In many cases, it is challenging for providers to identify these impairments without walking into the room with a high index of suspicion and regularly performing directed cognitive screening. So, what can we do? The most critical intervention is to recognize the impairment and educate the patient and family on how impaired executive function may interfere with adherence to treatments like medications or physical therapy. It is also so important to take the time to educate ICU survivors and their families in the outpatient setting. A systematic review by King et al. Found that timely and honest information from healthcare staff was the most helpful and valued resource during the management of PICS for ICU survivors themselves and their primary caregivers. Evidence also suggests that ICU survivors are being discharged on medications like atypical antipsychotics and sedatives. These medications increase the risk of accidents, infections, arrhythmias, and significantly add to the overall cost of post-discharge care. Most importantly, they do not improve the confusion or cognitive impairments associated with PICS. So remember to discontinue these medications in the outpatient setting unless they're rigorously justified. Now let's talk about the physical. Prolonged physical weakness, myopathy, and polyneuropathy may affect up to 1 in 3 ICU survivors. Common impairments include moderate to severe skeletal and respiratory muscle weakness, difficulty walking, and cases of complicated neuropathy. These symptoms may persist for years, severely compromising a patient's quality of life and placing heavy burdens on their family members. Many survivors require home health services and aggressive rehab for a long time, and unfortunately, physical impairments often lead to loss of employment, whether it be the ICU survivor themselves or their spouse or primary caregiver that has to come home and care for their loved ones, sometimes full-time. So what can we do? Referrals and encouragement. A systematic review by Calvo et al. Found that starting physical therapy early in the outpatient setting may be just as effective as early interventions in the ICU. For these patients, regular physical and occupational therapy reduces weakness and improves overall physical function. Also, referral to a social worker is recommended to discuss various financial resources and available support services, especially if the patient or the spouse has lost their employment or income. And finally, SCCM recommends that ICU survivors who have received any amount of ventilation would benefit from a referral to pulmonary or cardiovascular rehabilitation to improve symptoms like shortness of breath and prolonged activity intolerance. Now let's talk about the psychological. Mental health impairments associated with PICS are common, severe, debilitating, and often overlooked. Unfortunately, it is still a common occurrence for patients in the ICU to experience delirium and hallucinations, and it causes them serious trauma. There are reports of female ICU survivors who truly believed they were repeatedly sexually assaulted during tasks like catheter insertion, physical exams, bathing. The hallucinations are very real memories to these patients and can cause the same severity of PTSD symptoms as someone who had truly experienced those things. Many of us have seen the terror on patients' faces while they hallucinate that there are spiders over the wall or snakes, or maybe they believe that the nurses are trying to kill them, or they're in an MRI and they're screaming because they think they're on a conveyor belt into an oven. And these experiences are traumatizing, and the effects can be long-term and debilitating. A countrywide study by Hatch et al. Was conducted to determine the prevalence of psychiatric illnesses in ICU survivors after being discharged. 37% reported depression, 40% anxiety, and 22% met the criteria for a PTSD diagnosis. Another alarming finding was that ICU survivors with symptoms of depression were 47% more likely to die during the first 2 years after discharge than those who did not develop depression, which is concerning. So what can we do? Assess early and often using these standard tools. Many outpatient providers may be comfortable treating the complex psychiatric disturbances of ICU survivors, but if they're overwhelmed, early referrals to mental health professionals ensure psychiatric care and allow you or the provider to have more time focusing on one of the other complex comorbidities that go along with these type of patients. So now let's talk about cost. A systematic review by Sakisuk et al. Estimated that at least $18 billion is spent on post-ICU survivors annually in the US, and that was from 2017. So I'm sure the number has gone up quite a bit since then. Another study by Lone et al. Of 5,200 ICU participants demonstrated that ICU survivorship is associated with significantly higher 5-year mortality rates and 51% higher mean 5-year hospital costs compared to the hospital control subjects. That's an average of $10,000 to $20,000 per patient per year than matched patients who were hospitalized but not admitted into the ICU. Now we'll go to discussing a very prevalent topic these days, COVID-19. Due to the nature of the virus, experts are predicting a pandemic aftershock of long-term health consequences. Dr. Ellie, professor of medicine at Vanderbilt, said it eloquently. One of the best ways to avoid post-ICU syndrome isn't possible for coronavirus patients. ICU patients need to have humans around to orient them, to calibrate them, to touch them, to look in their eyes and make them understand what's happening. But that's exactly what the COVID patients won't get because they're all being so isolated. It's important to understand that episodes of delirium and the length of delirium are primary risk factors for developing PICS, and they are positively correlated to the severity of PICS symptoms. New isolation precautions make it very difficult for staff to implement delirium prevention strategies like the ABCDEF bundle adequately. Thus, PICS prevention strategies in the ICU have been significantly reduced. It is not premature to begin to think past the pandemic and prepare for the longer-lasting aftershocks of COVID-19. So, what do we know from the evidence? We know there are significant gaps in knowledge and awareness among key stakeholders, and this represents a significant barrier towards effective detection and management of PICS. The concept of PICS and the far-reaching consequences associated with ICU survivorship are well-known topics of interest among acute care professionals in the inpatient setting. However, PICS knowledge and awareness has yet to be adequately translated or gain traction within outpatient circles, which is a problem as they are the professionals most likely to encounter and care for patients and families at high risk or those who are currently suffering from PICS. Although epidemiological studies report a very high prevalence of PICS in ICU survivors, the syndrome remains under-recognized. This colorful document is the HABCM self-report screening tool. In 2019, this tool was validated as a screening method for PICS in the outpatient setting. It requires little to no training to administer, and it can be completed by the patient without staff supervision within 5 minutes. It is a very intriguing tool to help us detect PICS. Some words to ponder. Awareness is the greatest agent for change. So please be aware that as ICU survival rates continue to improve and outpatient clinicians encounter more and more patients with PICS, it is vital to appreciate the extent of associated cognitive, physical, and psychological hardships. Raising awareness and encouraging outpatient involvement may drastically improve patient health outcomes and elevate care and all of our practices. So this is the end of my presentation. Here are my references. please don't forget to take the post survey. And with that, thank you so much for watching and participating. We truly do appreciate it.